Good afternoon, everybody. This is Harindra Vijay Sundar. I'm the Vice President of Medical Devices and Clinical Interventions here at Acute, and I'll be moderating today's webinar on the role technology can play in addressing psychological trauma in a time of crisis. Certainly, the COVID-19 pandemic has been a trying time for many people. This is on the background of mental health already being a major concern across the country. On top of that, the pandemic has added isolation, financial worry, concerns about health and safety, and general uncertainty to this. And to make matters worse, the need for physical distancing means that access to traditional mental health services has been very difficult. We have three great speakers today to try to disentangle these complex issues. They are Dr. Rima Styra, who's a staff psychiatrist at the Toronto General Hospital and University Health Network, Louise Bradley, who's the President and CEO of the Mental Health Commission, and Effie Hellis, who's a Knowledge Mobilization Officer at Acute. We're going to start off with Effie and Dr. Styra with a tag team Q&A session. And after that, Louise Bradley will add some context to what Effie and Dr. Styra have talked about. And hopefully, time permitting, at the end, we'll have time for your questions. So with that, over to you, Effie.
Thank you, Harindra, and hello, everybody. I hope everybody's doing well during this time. So thank you very much for joining us today as we reflect on the events of the past few months and how these may have been a traumatic experience for some of us. When Dr. Styra and I were discussing this session, Dr. Styra thought that the words acute crisis should be part of the title. So for the next few minutes, we hope to provide some context around the psychological distress that may be related due to the COVID-19 crisis, discuss if internet-delivered cognitive behavioral therapy, or iCBT, can be an option in the mental health care toolbox. We will provide some key findings from a recent Acute review on iCBT for post-traumatic stress disorder, and we look forward to a discussion around the changes in mental health services in the context of this COVID-19 crisis. Next slide, please. So we thought that perhaps we can start with a description of what mental health looks like. There are a couple of descriptions on this slide. I will focus on the second one, which says that good mental health allows you to feel, think, and act in ways that help you enjoy life and cope with its challenges. Next slide, please. And with that, we go to this. And these are just very few images that are meant to reflect in a very limited way some of the aspects that we have experienced or exposed to during the past few months when our lives changed. Next slide, please. And in a way, also, we can perhaps say that the world stopped as well. We have seen big cities around the world and historic landmarks empty and international borders closed. Next slide, please. And then we had more intense situations. And I think this is a very striking image out of Italy. It shows military trucks carrying dead bodies out of the city of Bergamo during the peak of the pandemic in March, and they were carrying the bodies out due to capacity issues. Next slide, please. So Dr. Styra, do you think that the pandemic can be a traumatic experience?
Thank you, Effie. It's very important to know that the definition of a traumatic event is that there is actual death or a threat of death that occurs. So when you think about COVID-19, we realized that it was an emerging pathogen with really no known treatment that was effective at that time. As we saw the number of deaths increase in Wuhan, and as we saw really the outbreak spread to North America and hotspots develop in the United States, we knew that the outbreak was actually coming to Canada, and we would also suffer the loss of lives here. This really fulfills the criteria for a traumatic event, and therefore the pandemic is a traumatic experience for all of us. Next slide, please. I'd like to just remind everybody about some of the symptoms of post-traumatic stress disorder. We have difficulty with hypervigilance, negative moods. People feel more irritable. They feel more anxious. They might have flashbacks. They have difficulty sleeping. And one of the other things that occurs is a comorbid substance use problem that develops. Next slide, please. There was a lot of work done when we had SARS here in Toronto in 2003. And what we found was that both healthcare workers and the general public who needed to be quarantined, and here we're thinking about people who had actually been exposed to someone who had been diagnosed with SARS, exhibited symptoms of PTSD as well as depression. And the symptom range really was about 30% prevalence rate. Next slide, please. When we think about COVID-19 now, there's been a lot of work that's actually come out of China. And again, similar kinds of effects, post-traumatic stress symptoms, anxiety, depression, but the percentages are actually higher at this point. It's about 50% that the literature is showing us. And this makes sense because SARS was a much more limited experience. We didn't have the high mortality rates that we had now with COVID-19. There was community spread. There's been major economic effects as well as limitation of activities. So not surprising to see higher percentages of mental health distress. Next slide, please. There's not actually been a lot of work done in terms of the general population, but there have been a number of surveys that have been done. And this is a survey that was done by the United Nations that really looked at a number of countries. And what you can see here is that the distress levels are fairly high that are reported by individuals. There was an Angus Reid survey that was done of approximately 2,000 Canadians. And what they reported was a 50% negative impact on their mental health. Next slide, please.
Thank you very much for this context, Dr. Styra. You referenced the recent UN policy brief that calls for action to address the psychological distress in the population due to COVID-19. In that policy brief, they focus on specific populations, and these include older adults and people with pre-existing conditions, children, adolescents, and young people, women, people in humanitarian and conflict zones. But on top of the list are first responders and healthcare workers. Next slide, please. So some of us may associate post-traumatic stress disorder, psychological trauma, and moral injury with the veteran population. However, we now know that healthcare workers are also vulnerable and at risk. And this is a title from a recent New York Times article that also mentioned that in New York, the city has joined with the Defense Department to train 1,000 counselors to address the combat-like stress for medical workers and emergency responders. Next slide, please. So Dr. Styra, you are a clinician. Could you provide us with your perspectives on how clinicians and healthcare workers are affected by this pandemic?
Mm-hmm. Next slide, please. So the effects for healthcare workers actually really started in what we would call the pre-disaster phase. We were anticipating a pandemic. None of us had ever experienced anything like this throughout our entire lifetime. So many feelings that arise in terms of distress, concerns, and fears. And what was also happening is that there was a lot of apprehension because we were hearing that we were going to be deployed. And deployment really meant that we were going to be practicing out of scope of practice. So we would actually be doing things that we had not done previously or had not done for years in terms of treatments or various interventions. It was a ramping up time. There was also a lot of concern about PPE shortage that we were hearing about. And as practitioners, we had learned specific infection control measures, but all of a sudden this was being turned around. And the guidance associated with that was changing on a daily and a weekly basis, adding to the uncertainty that we were feeling. We were also hearing about the fact that we were going to have ventilator shortages. And that really meant that we were thinking about triaging patients. Who was going to get a ventilator? Who wasn't? And that's an extremely distressing factor for any healthcare worker. And there were plans for when healthcare workers were going to get sick. So one would see one's name appearing if so-and-so became ill, you were stepping into their place. Our COVID-19 patients started to arrive, and that's when the active work really started. What we thought about was the risk that we would have to ourselves and to our family, to our colleagues. So it wasn't just that we might get infected, but we might actually bring it home. And then the concerns about childcare and elder care. We had children at home. We had elderly parents that we might be actually taking care of. Could we self-isolate in our home? Did we have to send them away somewhere else to stay while we were working? Or did we actually have to find new housing? And then just the practical kinds of things that were concerning. We needed to get groceries and other aspects. Lots of uncertainty. How long was this going to last? How bad was it going to be in Canada? Fortunately, we've had lower numbers than the United States, but it still meant that we were tired, we worked long hours, we wore masks for long periods of time because we were trying to preserve the PPE. So healthcare workers were wearing the same mask for long periods of time. And also, it really meant that we didn't have as much facial expression and interaction with our patients because a mask really covers a lot of the facial features that we have. We also had the loss of patients, and it was very heartbreaking for many of us because these patients were dying without family members. We have a no visitor policy so that they were dying alone with only the healthcare workers there for support. We were distressed. Had we done everything we should have done? Were there other things that we could have done better? And when you think about protected code blues, whereby you see a patient that really needs support, and yet the healthcare staff also need to make sure that they're donning PPE and protecting themselves and their colleagues. A positive thing was the community cohesion, where the community came together. And what the community actually did was they self-isolated and they tried to flatten the curve, which was very encouraging. However, as time has gone on, what we've seen is the community is starting to move on. But in actual fact, COVID-19 is still a huge reality for those in healthcare and working in the hospital system. Next slide, please.
Thank you very much for this perspective, Dr. Styra. And perhaps we can expand a little bit from the healthcare worker population to the general population. Again, this is something that was quoted in a recent CBC article the other day. It said that Canadians were already in a mental health epidemic before the pandemic began. What does this mean now, perhaps for the general population?
Next slide, please. So we're all aware of the fact that there is a tremendous lack of mental health resources in Canada. And what we're thinking is that during the pandemic and post-pandemic, we're actually going to have a mental health pandemic. People are very aware of post-traumatic stress symptoms at present. It's been highlighted in terms of the military and veterans. And what we know is that treatment for PTSD is really quite scarce. There's not a lot of centers that offer this type of treatment. So what happened during COVID-19 is that we all needed to kind of think about how are we going to treat our patients? How are we going to provide support? How are we going to be able to interact with our patients and continue our practices? And even though we had telehealth before, many of us were using it very sporadically, just on occasion. And what happened was we all turned to virtual care. And what became very apparent very quickly was that practitioners thought, oh my gosh, there's a lot of benefits to virtual care. And the other thing that happened was we had a positive response from our patients. They really felt that this was an excellent way to be communicating with their healthcare provider. So all of a sudden we started to identify all of these benefits of greater access, flexibility in the system, efficiencies were noted. So what was happening is we felt like we discovered a new tool, a new resource. And maybe this new resource or new tool that we've discovered, even though it's been there for a long time, with its increased use will actually help in minimizing the lack of mental health resources that we have. Next slide, please.
Probably most of us by now have experienced that shift to virtual care. Next slide, please. So the question is whether, with limited access to face-to-face treatments, technology can play a role in addressing psychological trauma. Next slide, please. So for the next few minutes, we will go over some key findings from a recent CARET review that I mentioned earlier on iCBT for post-traumatic stress disorder. This review was completed in January of 2020, and CARET's advisory body, the Health Technology Expert Review Panel, reviewed the evidence and provided recommendations on the use of this technology. Next slide, please. So for the next few minutes, I will provide an overview of the key findings on behalf of the team. Next slide, please. So perhaps we can start by mentioning that cognitive behavioral therapy is one of the most frequently used evidence-based psychotherapies in the treatment of post-traumatic stress disorder. And the components include controlled exposure to the memory of the trauma and also a cognitive restructuring of unhelpful thoughts and perceptions of the traumatic experience. Now, iCBT, CBT, that is delivered through an online platform, the individual does not have to go to the therapist's office for that, but they do need an internet connection and the use of computer, smartphone, or tablet. iCBT programs typically include a series of structured modules with clearly defined goals, and readings, activities, and messaging may be part of the program. And iCBT may offer ways for individuals to overcome certain barriers to timely and effective care. And these barriers may be fear of stigma, geography for those who live in remote areas, and barriers to accessing care and providers due to shortage of therapists and long wait times, among other barriers. Next slide, please. iCBT can be provided with the support of a therapist, or it can be self-guided. And I think at this point, we should also mention that the level of support and also the different components of iCBT programs may vary between programs. Next slide, please. So when we embarked on the review of the evidence, we knew that a wide variety of iCBT programs are currently available in Canada, specifically for certain conditions such as anxiety and depression. And we knew that concrete frameworks for implementation and integration of iCBT into the clinical practice have not yet been established in Canada. We also knew that there is increased interest in the option of iCBT for PTSD and interest in understanding the appropriate use of iCBT for the treatment of this condition. Next slide, please. So the Carrot Health Technology Assessment aimed to support policy decisions and implementation decisions, and it was guided by two questions. Should iCBT be used to treat individuals with PTSD? And if so, what factors and considerations should guide implementation of iCBT in the treatment of PTSD? Next slide, please. So we did a comprehensive review of the evidence, and that included a review of the clinical effectiveness and economic evaluation, a review of perspectives and experiences of patients, families, and healthcare providers, a review of ethical issues, and implementation considerations for iCBT for PTSD. Next slide, please. So for the next few slides, I will focus on the key findings of each of those separate reviews. But for those of you who are interested, I am including a very brief summary of the approach to the methodology for the review. So for the clinical effectiveness review, the evidence showed that iCBT may be more effective than the wait list for improving the severity of PTSD symptoms, depressive symptoms, symptoms of anxiety, and for improving the quality of life for adult patients with PTSD. However, it is uncertain whether the reported improvement in symptoms is clinically meaningful. And in addition, the clinical effectiveness of iCBT compared with face-to-face psychotherapy is not clear because no evidence was identified. And similarly, the safety of iCBT for PTSD is also unclear. So the major caveat here is that there are numerous concerns regarding the certainty and the quality of the evidence for the clinical effectiveness. Next slide, please. So with that in mind, the economic analysis was also constrained by the available clinical evidence. So the main finding from the analysis was that iCBT was associated with lower total costs and greater quality adjusted life years compared with no additional treatment, which that could be wait list, usual care, or delayed treatment. And again, with the limitation of the clinical evidence, the cost effectiveness of iCBT in comparison with other psychotherapy interventions, including face-to-face CBT, remains uncertain. Next slide, please. So for the perspectives and experiences, the key finding was the importance of establishing a strong therapeutic relationship between patient and provider, as this is a key component for the success of the treatment. And iCBT programs could benefit from creating that space for these relationships to be established. Another point is that treatment can be world-changing for patients. For some of them, it may be a cause of concern as they don't know what change may mean in their lives after treatment. So providers should consider assessing readiness and motivation with this in mind. And throughout the literature, it was quite evident that there is a need for tailoring to the needs of the individual. So it seems in that context that it is less likely that unguided iCBT for PTSD would be considered as useful for patients. Next slide, please. So the ethics analysis aimed to identify and reflect on key ethical issues that should be contemplated for the provision, development, and use of iCBT for PTSD. And here we have the key findings from that. So the first one is the consideration for the extent to which trauma-informed care can be offered in the context of iCBT, so that re-traumatization is prevented and client safety is prioritized, especially in the context of iCBT that is not therapy supported. The second one is the consideration that while iCBT may enhance access to care for some, this is not the case for other less privileged individuals due to the digital divide in Canada, as we know, as well as social determinants of internet access. And the last point here is the consideration of establishing a trusting alliance so that iCBT providers can fulfill their ethical obligations within this context of online treatment. Next slide, please. So the last component of the review looked at implementation issues related to iCBT for PTSD. In addition to reviewing the literature, we also consulted with 15 stakeholders across the country. We know that iCBT for PTSD programs in Canada are in early stages of development and availability. However, several issues for implementation came forward. So these include the need for regulatory oversight to determine what qualifies as an iCBT program, which professionals are appropriate for providing care with iCBT. Also, where iCBT should fall into the clinical practice pathway, clinical care pathway, and considering the appropriateness for iCBT that should be contingent on the severity and the form of trauma and the presence of comorbidities. And on a system level, considerations such as the funding for mental health care in Canada, the digital divide and data security are also, they also play a role in the implementation of iCBT. Next slide, please. So based on this evidence, the expert committee concluded that internet-based cognitive behavioral therapy may have a role in the treatment of adults with PTSD. However, at present, relevant evidence is insufficient and of low quality. Therefore, evidence of higher quality will be needed to inform future implementation and policy decisions. Next slide, please. However, the committee provided a number of aspects to be considered for those who are interested in using iCBT for the treatment of PTSD. An emphasis in those considerations was given for assessing the appropriateness of iCBT for each patient through diagnosis and referral, choosing therapist-guided iCBT, using iCBT as one component of a stepped care model or in conjunction with other therapies, and finally ensuring that personal health information is safeguarded. And with that, Dr. Styra, the last question from me to you. Next slide, please. You are familiar with this work. You were part of the expert committee that formulated the recommendations. What does this evidence mean now in the context of the COVID-19 pandemic?
Next slide. So I think what we all know is that with every disaster, it really leads to mental health crisis. And it doesn't matter whether it's a natural disaster, whether it's a mass shooting, or it's a pandemic, there's going to be a major impact on the population of anxiety, depression, PTSD. And what's been happening is that now there is a greater interest in developing iCBT programs. And part of that interest is the fact that both the general population and patients and healthcare providers have told the province we really need funding for these programs. And there's been enthusiasm and uptake for funding by a number of provinces, including Ontario and Saskatchewan. It's also very helpful, as Effie described to us, that we now have guidelines that will help us to assist with the development of these programs and give us a roadmap that we can follow. There is also a tremendous amount of funding that now is available through CIHR and other research programs in the context of COVID-19 to develop iCBT programs for PTSD. So we have now finally the potential to expand the knowledge regarding the safety, efficacy, and logistics of iCBT. Next slide, please. So what we're thinking is maybe remote care really is going to be an improvement in terms of access to mental health, because we're going to have less of a reliance on the office structure. It really means decreased costs. We can be addressing more patients as opposed to one therapist on a one-to-one basis. Travel, decreased travel for the patient, decreased travel for the practitioner as well. Time efficiency, the number of no-show rates for virtual care, much lower than for actual office visits. Effects maybe on stigma, not as stigmatizing. And iCBT is wonderful for consumers because it's convenient. They can use it whenever they need it. They can use it maybe after they put their kids to sleep, during their lunch hour, before they go to work. It's also available when they need it. So if you're feeling distressed, you need to speak to your therapist. It's available at that point. Or you need to review a module or participate in some other activity that will help decrease your anxiety and your distress. It's portable. And you as the consumer decide on the pace. It's not the therapist who's telling you you're coming every week, every 2 weeks. You decide whether you need to go slower, whether you need to go faster. So you're able to kind of manage what it is that you need, and it's much more geared to you, the consumer, and your particular needs. So lots of positive things, but we've got to also think about the limitations. And even though technology's opened up the doors for a lot of us, basically, it's important not to leave those without technology access behind. And we need to really think about ways that we can actually bring everyone into the fold. We also need to keep in mind that we still need involvement of local healthcare, because we're going to have issues whereby we're going to have a crisis and we're going to need face-to-face involvement, or an emergency such as a suicidal patient, and they're going to need face-to-face contact and care at that time. And there might be a population also of individuals with severe mental health problems that will need more hands-on face-to-face interaction, and that's beneficial in part of their treatment. Next slide, please.
Thank you, Dr. Styra. Harindra, over to you now.
Thank you very much, both of you. We're now going to turn over to Louise Bradley to hear her perspective on how the COVID-19 pandemic has affected mental health and mental health services in Canada. Over to you, Louise.
Thank you very much, and thank you for those wonderful presentations. I'm going to talk a little bit more, adding on some of the points that have already been made beautifully so. And start off by saying that, like the poll that was referenced earlier, the Mental Health Commission commissioned NANOS research and found exactly the same results, in that stress levels for Canadians had doubled from the month before the pandemic hit us. Interestingly enough, just a couple of weeks before the pandemic got into full swing, the Mental Health Commission of Canada, along with UBC, the University Health Network, and the Centre for Addiction and Mental Health, hosted our 9th e-mental health conference. And this year it was called Caring in a Digital World, Introducing Disruptive Change to Mental Health Care. And I think it was really quite fitting, because none of us at that time knew exactly how much that was going to help in the coming weeks and months. As has already been referenced, mental health services and the provision of health care for those with mental illness was a challenge long before COVID hit us. The funding issue and the parity between mental health and physical health has long been of great concern. And despite those of us who have been advocating for parity between the two, it has been to no avail. However, since the pandemic has hit, there is now much more attention being paid to mental health. So we had already been trying to find new and better and innovative ways of service delivery, because it was simply unacceptable that somebody going for help would be put on a wait list for 18 months, and that wasn't an uncommon experience. So a couple of examples of being responsive to that is that the Commission, in collaboration with then the Government of Newfoundland and Labrador and Dr. Peter Cornish at Memorial University, I implemented a stepped care 2.0 model, and we researched that for quite some time, only to find that in Newfoundland there was a reduction in wait times by 68%. In some of the clinics, there was a zero wait time, which was virtually unheard of. It was a combination of e-mental health, the use of apps, which is a whole other session, I think, on that one, and also the use of peer support services. The beauty of this one, of Stepped Care 2.0, is that the individual gets to choose themselves as to which level of care is required and what they may need. And I think that's extremely important to utilize the voice of lived experience and to truly listen to people when they say what they need. One of the things after the pandemic struck, when we're talking about how traumatic and difficult this can be for essential workers, is that two programs that the Commission has, two training programs, Mental Health First Aid and The Working Mind, which are face-to-face interactions ranging from a half a day to 2 full days, was very quickly transported into virtual courses that were only a matter of 2 to 3 hours and was provided to essential workers. One is called Caring for Yourself, the other one is Caring for Your Team, and the other one is Caring for Others. And basically helps people to develop resiliency in order that these stressors and, quite frankly, normal responses to abnormal situations are able to develop resiliency skills to prevent it from going into a full-blown crisis. These courses are still available, and there will be links sent to you to the participants in this webinar at the end of the session today. And it has been amazingly successful, so much so the first week of the launch of these courses that the response was such that it crashed our servers. And we had to deal with that, but a good problem to have. There's also some posters that are available for people to utilize as well. There's also one other that I will mention, and that is a virtual crisis response specific to veterans. And so Caring for Others in the veteran community is free to veterans and their families, and that is also being utilized quite a bit. I think the reference earlier to confidentiality is something that we're still working on and requires work, and we're working with our colleagues internationally to try to address that. There are many lessons coming out of this crisis, and I, for one, see that this is a real game changer. There are many things to be learned. I think and hope that it will not go back to the way it was, where we relied on physical interactions and that bricks and mortar were the requirements to providing excellent service. I would also encourage people to visit the Commission's website, where there is a hub that outlines good and credible resources that are available. And the Government of Canada has a portal called Wellness Together, which also provides virtual care to people experiencing difficulties during this crisis. Also, one final thought on the vulnerable populations. I think that I've also been hearing about some wonderful ways of trying to deal with that in terms of providing access to homeless populations so that they can access computers and telephones and that sort of thing. So the big concern, of course, remains with people with pre-existing conditions and had already been diagnosed with mental illnesses that require face-to-face contact. But I think that overall, virtual care has a place in the provision of mental wellness and mental health care. And I sincerely hope and believe that it will continue. Thank you so much to Cadith for hosting this today, and it was wonderful to be a part of it. Thank you.
Thank you, Louise. So we do have about just under 10 minutes for questions, and we've had a few that have come in through the Q&A function. If you have any others, please put them in. So we have a few questions that are concentrating on the concept of the digital divide that has been mentioned a few times during the webinar. And so perhaps I'll start with Dr. Styra to ask her to try to address the idea that there is systemic inequity of access to digital care. But along the lines of the COVID-19 pandemic, we've also seen the Black Lives Matter issues that have really come to head over the last few weeks that have been speaking about populations that have been systemically disadvantaged, and how when we move towards this remote care approach, how do we work to ensure that populations that have been historically disadvantaged don't continue to be with these new types of care?
Mm-hmm. That's a very important question, because I think we all realize that there are many in the population that really need mental health resources. And in actual fact, this digital divide is an ongoing issue that's based on a lot of socio-economic kinds of issues. I think Louise kind of alluded to the fact that, for example, in the homeless population, they were making provisions to provide them with some internet access or phone access so they could actually get support for their mental health issues. But I think it's a very difficult situation whereby we really need to reach out to the populations that don't have the technology available. And we need to really be creative and think about ways that we can actually get the help to them that they need. I don't think I have the complete answer to that, but I think it really involves us working very hard together and involving governmental sources as well and other technology groups to help us move this particular group forwards.
Louise, do you want to make any comments about what the Mental Health Commission has done in this area, disadvantaged, marginalized populations? Also, any potential cultural overlays that you've had a chance to think about?
Well, you know, it is a very difficult situation, and unfortunately, I think some ways that's all we have been doing is thinking about it. When you look at our northern populations and our many Indigenous peoples in Canada who are living in the north, the bandwidth simply does not allow for virtual care in the same way that it does for those of us in more urban settings. And you know, I think it is something that we are really going to have to address in the near future, immediately. And it's going to have to be with the help of unusual suspects in a way, because our telecommunications partners who can help with this, I think are going to have to help. Government, federal, provincial, and territorial. There has to be a way to find, to allow access to these services in our northern territories. And as I mentioned, with vulnerable populations, it's almost becoming as essential to, for example, people living on the streets, for them to have access to the internet and to phone communications as it is for them to have shelter and food.
Great, thank you, both of you. I'm going to direct this next question to Dr. Styra. There have been a few questions related to the fact that iCBT can be therapist-guided, it can be self-guided, and it can make use of other advisors or coaches. Can you speak to what the data says or your own clinical experience of the importance of having coaches and advisors in this role?
Oh, it's a great question. So actually there was a lot of debate about this when we were actually thinking about the guidelines. And part of the issue is that we know that PTSD symptoms can vary from being quite mild to much more severe. So we were trying to figure out ways in terms of thinking about what is going to be the population that's going to benefit most from involved iCBT that might be basically more self-directed versus those that really needed guided therapy basically. And some of the things that came up was the severity of the symptoms. The more severe the symptoms, the more likely they're going to need therapist involvement. The type of trauma that had occurred will also help dictate whether they need a therapist or not, whether it might be more intrusive having a therapist, or it actually might be helpful to have someone available there that they can reach out to when they have a crisis. The other thing that we thought about was the fact that really we do need to have a therapist sometimes available, because if there's no one for them to reach out to, how do we actually address the patient who might be suicidal, who really needs assistance at that point? And if there's no way for them to basically reach out, then we're really missing an opportunity, and it would be a concern that their mental health would actually decline.
I'm going to switch gears a little bit to speak about, there's been quite about PTSD and how it relates during the pandemic period, specifically for patients and residents who have been restricted from family and caregiver support. I'll direct this one also to you, Dr. Styra, from your professional experience. That certainly, it is singularly unique in my clinical experience to be at a time where visitors and family members have been restricted from the care process. So your thoughts on that and how it's related to the trauma theme?
So I think the way that's really related to the trauma team sort of depends on also sort of the group that you're coming from. There are more vulnerable groups, for example, who might have had mental health issues previously, and the self-isolation has just actually exacerbated their symptoms, especially when you think about the fact that they're more self-isolated. They already might not have had as much contact as they had previously, and now we've actually minimized that contact. And for people who have an underlying anxiety disorder, one can understand that the risk of infection and the thoughts that they might have just going out to get groceries or to get essentials that they have might really impact their level of anxiety. And avoidance of kind of traumatic thoughts, avoidance of traumatic kinds of experiences. For example, if they're very hypervigilant, you go out to the grocery store just for that brief period and somebody there sneezes. What does that mean to you? What does it mean in terms of their anxiety level? So I think what we were seeing was a lot of negative effects as well in terms of mood. People were becoming much more depressed when they were self-isolating. And what we also thought about was our elderly population that really might not have, and this is where some of that technology divide also comes in. They didn't have as much ability to socialize over the internet as maybe some of our younger individuals did. So they couldn't reach out by using Skype or Zoom to other members because maybe sometimes they didn't have the technology available, but also they sometimes don't have that support available to them. So I think what we're seeing is a lot of the effects in terms of the isolation that people felt when they were self-isolating, but also we're thinking about another group of people that were also very vulnerable. And those were the people who basically, you think about domestic violence So now, all of a sudden, if you had been someone who was being abused by a spouse or a partner, you're actually forced to be in the same environment day in and day out as you're self-isolating, and the impact that that would actually have on you. And that would also lead to the development of some post-traumatic stress symptoms.
So thank you. A lot of really critical points that you've raised, and we unfortunately have run out of time. There are a lot of other questions, and thank you to everybody for bringing those questions forward, and thank you to all our speakers for a very informative and important session. This webinar will be posted on CATHET's YouTube channel by early next week, and we do have another webinar coming in a couple of weeks. You can watch the CATHET website for details. So again, thank you again to all our speakers and to all of you for joining us this afternoon. Good afternoon.
Thank you for having me.